Welcome, everyone, to another session of Conversations with the McGill Office for Science and Society. COVID plus more is how we label these. And today, joining me is Emily Shore and Jonathan Jerry from our office. And all the way from across the pond, actually several ponds, is Dr. David Zlotnick, who's in Israel. He's the medical director of the TEREM clinics there, and he's an emergency physician. So welcome, everyone, and we're going to get started with David and how things are going in Israel.
Well, thanks for having me again. Well, right now in Israel, we are sort of very slowly coming out of the second lockdown. It was, as we discussed in the past, Israel went into a quite strict lockdown the first time, and our numbers were looking really, really good. And then sort of Israel got decided to come out of the lockdown quite quickly, and there was sort of a lot of there was sort of a lot of happiness, and everyone was very self-assured in the fact that they brought the numbers down, and things went sort of escalated very quickly once they released from lockdown quicker than sort of they planned to, and the numbers went extremely high, and we were at one point having about 10,000 new patients a day. We were having the infection rate, the number of patients who had COVID compared to the patients who got tested was about between 10 and 11% at one time, which was super high. So at that point, around the high holiday time here, when things sort of slowed down anyway, so right before the high holidays, the country went into its second lockdown that lasted almost about a month. Quite strict, not as strict as the first one, in the sense that in the first time you were not allowed to go more than 100 meters outside your house. And 100 meters is like, walking across the street to throw away the garbage, basically, on a corner. But at this time, you were allowed to go about 1 kilometer, and you were allowed to exercise. So it was a little bit less strict. I would say, like, the first time I could drive home from work, a drive that would take me 40 minutes in traffic took me like 12 minutes. And this time there was still traffic the second time, so it wasn't as, people were still going to work. It wasn't as strict, but still there was all the national parks were closed, everything closed down, and the numbers got really under control. Currently we're maybe at a positivity rate of about 1.6%, and we're seeing about 500 patients a day right now. So a huge improvement to what it was before, and we've come out of the closure this time much, much, much slower, much more calculated.
What do you mean seeing 500 patients a day who are symptomatic?
Saying 500 positives a day.
500 positive tests.
500 positives. Yeah.
But
sorry, when I say 500,
I'm trying to, so two things that I know Joe will have questions too, but it's so crazy how, Israel was so proactive in like the lockdown, and so important, and you guys jumped on it. And then like you had no reopening strategy, right? The first, you kind of let the floodgates loose. And I remember that you were on and you were like, I don't think this is the best, thing to do. And then we had Debbie Schwartz also on saying, like, Montreal, Quebec didn't also have such a great, reopening strategy. But I'm so curious, because if your second lockdown was a little bit looser than your first, you still said people were going to work or whatever, and you could still run, go for a run. Yeah. Like you still saw significant improvements. Whereas, Absolutely. Here right now, we could talk to that also. In Quebec, we're not seeing improvements despite the red zone that happened October 1st. So what do you think?
Not only are we not seeing improvements, it's getting worse. Today is over 1,300 positive cases, which I think is the most.
And they don't know what it's being attributed to, really. I mean, one can surmise, but technically a lot of things are shut down.
A lot of talk about schools, that it's kids bringing it home from schools.
Well, and in Israel, so schools closed.
So
right?
Yeah. So I'll say in Israel, first of all, I guess it was also when the second lockdown happened. You could imagine like the Christmas, New Year's time you have. Like it's in North America or anywhere else. So sort of that week is kind of really super slow, and most people aren't off work and stuff. So imagine that like for a month, like around the high holidays, it's like a long period like that. So already you had even people going to work, but it made sense. It was already less people out, and they really didn't allow you to go on any hiking or out. Not that I think that being outdoors by yourself in a hiking, even in a group, but like they really didn't let any gatherings. And the police were going around giving tickets. Actually, they were quite strict about that. So that all, I think, in combination really drove the numbers down. And instead of release, I mean, the Middle East isn't exactly known for its patience. People are, so the first time I was not, I didn't think it was good, but it's super. I don't think it was super surprising that people were like, okay, let's kind of get on with this and get out. The first time, and people were learning. I mean, every country is learning. It's the first time we've dealt with this in our lifetime, and I try to give people a little bit of slack that no one really. I mean, there isn't a great strategy because they're sort of everyone's learning. But we've learned now that we've learned from the first, exiting of the lockdown and the second wave that happened much worse than the first with regard to the numbers. So the second lockdown, again, much more calculated. Kids who are in school above grade 4 still on Zoom. School hasn't returned. All the malls are still closed. Restaurants are still closed. They just last week opened up stores that are facing the outdoors, with only 4 customers allowed in at a time, 2 meters apart. Much stricter.
But malls. Retail stores are open here. I mean, restaurants are closed, and even the terraces, like the patios, are closed. Even though none, I really do empathize with the restaurant owners, because they do say, like, show me the cases that came from our restaurants, right? Especially from just the patios. But if you just want to stop everything, that would be on the list to stop, but then stop malls and maybe stop schools for a little bit. Like right now we're heading into Christmas, right? So maybe it also makes sense.
Well, anyway, before we get around to the vaccine, which of course we have to discuss, there's the question of, how we know which direction we're going. What are the metrics? And one thing that is talked about a lot these days, especially in the US, where they're crowing about how well they're doing, which of course is total nonsense, by looking at the percent of people who die relative to the total number of positive tests. And indeed, that has been going down in the US. But this is really not a meaningful measure. The most meaningful measure is how many people are dying per 100,000 population. And there, of course, the US is doing very poorly. But this is something that I discussed both with CD and with Jonathan. This conundrum here that in the US, the percentage of people who are dying relative to the positive test is actually decreasing. And of course, this is what Trump has been talking about, that US is doing well. Well, it isn't really surprising, I think, I don't think we've totally pieced it together, but I think it isn't really surprising what's happening for several reasons. One is that in the US now, more and more young people are being diagnosed as being positive. And obviously, the more young people you have diagnosed as positive, the lower the death rate is going to be, because the death rate among the young is much lower than among the seniors. And then we also have the situation in the US where testing is not just random. The testing is pretty well limited to people who can afford to pay for the test, or who are at least middle class or higher. So you have a selected population here who already probably has a healthier lifestyle and fewer underlying conditions. So I don't think it's really surprising. Plus, there's the fact that fewer people are dying because there are treatments now, right? I mean, there is dexamethasone, there's remdesivir. They are learning how to not use ventilators, right? How to turn people instead on their stomach. So, yeah, hospital treatments are getting better. So, yes, the percent of people who are dying relative to the number of infections documented is lower, but the absolute number of people who are dying is far higher. So, I mean, the real percentage that we should be looking at here is what is the percent of positive cases relative to the total number of tests. And that's what's increasing. So, Jonathan, what do you think? I mean, we talked about this the other day, this surprising thing that in the US, they claim that they're doing well because of this percentage.
I don't have much to say because I'm not an epidemiologist, and you and I had back and forth over email over this, and it can be quite difficult to reconcile all of these different variables that don't seem to make a lot of sense. But as you pointed out, when you have a younger fraction of the population that gets infected, de facto, you're going to have fewer severe cases, you're going to have fewer deaths. But then these people might go on and infect elderly individuals eventually. So you might have this sort of this other wave of deaths, unfortunately, as the disease goes from younger people to older people.
Right. I mean, therefore, claiming that because that percentage is going down, therefore they're doing well is unrealistic. What is realistic is the number of people dying out of every 100,000 people. That's a hard number. I mean, we know what that number is, and that number keeps increasing.
Yeah, so anyway. I heard someone say the other day on a Zoom meeting, that they were talking about COVID, and they knew people that had it now, and more people, and it wasn't as bad, and they just had, it was, they were out for a few days and they didn't feel well. But then I jumped right in saying, but everyone experiences it differently. Just because someone has this, doesn't mean you'll react. I said, I heard someone who was pregnant and had it, doesn't mean I want to have it, everyone reacts differently. So
anyway, Steve, you had a good analogy there the other day with the water bucket.
Yeah, I was sort of saying that, we talked about the fact that you have to look at who's getting tested in the United States. And, certainly in places where testing, there's some kind of financial, we were, lucky to live in Israel and Canada. That's pretty much free healthcare for everybody. And that's not really a financial consideration so much. Who's, if you need care, if you go to the emergency room, they're not going to need care, they'll care for you. Where in the States, this is obviously is a huge financial issue there. And so that's one thing. And the other thing we spoke about as well is, in the States, healthcare is very much associated with your employment, and your healthcare insurance is associated with your job. And if you're in a lower socioeconomic status, a lot of people I've heard of don't want to get tested, because if they get tested and they have to take 2 weeks off and they're in a job that's easily replaceable, you've now lost your job and your health insurance. So a lot of people aren't getting tested. So if you sort of look at a population, I'm saying you put the population of, for example, Canada in a bucket, and you put the population of positive, of the United States, it's not the same people who are getting tested. I think that in Canada, the people who are getting tested, you'll have more of a bell curve distribution. Whereas, again, this is all, theory, but in the United States, where the people getting tested are sort of the ones that financially can bear being tested, in a sense.
So you end up comparing apples to oranges when you're comparing Canadians get tested versus Americans who get tested.
Yeah, so you're taking the number of deaths from the people getting tested, and you're looking at that and you're saying, well, that's a different population of people getting tested. So I think that might also come into play, although, again, this is theory still, but as we were discussing.
Well, we'll see, how this evolves, because, obviously, in the US here too, the number of positive cases are increasing. So we'll see how that percentage varies. But one thing we can agree on is that the situation is not good here, there, or anywhere. That's the problem.
But the COVID fatigue, because our numbers are not going down like they were at first, right, Joe? I don't know if you feel the same. People were still encouraged, and the politicians were encouraging us, and we were encouraging each other. They are going down. They're not now, and I really do find that the fatigue is real. People
absolutely.
are not.
But anyway, there is this glimmer of hope, because we had this press release, and let's just mention that science in general is not done by press release. It is done by proper controlled trials, which are published in the peer-reviewed literature. However, of course, because of the situation now, where everyone is clasping at every straw, we pay attention to press releases, and Pfizer's press release was very impressive, with the claim that the vaccine that they have been testing is 90% effective. That's the kind of number you really want to see, and you rarely see that in vaccines. With the flu vaccines, you're happy if you're getting 70% success rate. So 90%, we're approaching measles quality, and that's as good as you can hope for. So that result looks very good. But let's dissect this for a moment. What they did, for those people who are not familiar, they enrolled 44,000 people and divided them into two groups. One group was the experimental group, the other the control group. They all got injections which looked and felt the same to try to avoid the placebo effect. But the experimental group got the real vaccine, and the control group got just saline injections, 3 weeks apart. This is a two injection vaccine system. And then they followed these people to see who would get sick. And at this point, there's 94 people who have gotten sick with the virus, which is a surprisingly low number out of the 44,000 people. One would expect more. So that is an issue there. So really here we're talking about basing this 90% optimistic projection on 94 people. Now, the question was, these 94 people who were infected, which groups were they in? Were they in the placebo group or in the vaccine group? And 90% of them were in the control group, meaning that they were not being protected because they didn't get the vaccine. So that's where the 90% comes from. It is realistic based on this study, but we're still, talking about preliminary results. And Pfizer itself says that this study has to go on for 2 years until we know whether or not there are any significant complications, because the form of this vaccine is quite different from other vaccines that we have had. This is a messenger RNA vaccine in which what is injected is basically the blueprint for the making of some of the proteins that are on the surface of the virus, so that the human body will start making those and then develop immunity against those specific proteins, so that whenever the virus gets into the body, the antibodies will recognize the proteins on the surface of the virus. Anyway, it's this new technology. Never before has there been an mRNA vaccine that has been put on the market. So therefore, I think it needs, extra special vigilance to make sure that nothing untoward is happening here. But anyway, I mean, at this point, the results look good. So, I mean, Jonathan, what do you think? What you see any issue here, flaw?
Well, I mean, it's everything that you pointed out. I mean, it's a press release. The trial is not over yet. The numbers that you're quoting and from which this percentage is drawn are quite small. And of course, it's a bit of a gold rush. All these companies are trying to come up with a vaccine in time. So obviously, whenever you have something that's worth, sharing, you share it, even when it is preliminary. I am hopeful that there will be several vaccines that will eventually be approved and that will have good enough efficacy. Will Pfizer's vaccine hold up? It's too early to tell. I mean, as you said, it's signed by press release. I understand that, first of all, their shareholders want to know, but I also understand that people in general want to have something onto which to cling their hopes. I'm hopeful for vaccines in general. Pfizer, we'll see. It's a press release.
CD, what do you say about the vaccine?
I mean, I certainly agree with the issues you brought up. Certainly, I still do think that there's a glimmer of hope here. Big issue will be also how long does immunity last? I mean, you don't know that. I mean, if you have a vaccine that gives you 3-month immunity, so it's very different than giving you immunity for years. So that's one huge piece of data that's missing. And although the trial might go on for 2 years, it seems that they will fast track this and release it, from what I'm hearing, within a few months, possibly already given to the public. So it's not like people listening will think that it'll take 2 years for us to release this vaccine, but it looks like, given the situation in the world, that they will fast track this. And,
I mean, Pfizer is equipped apparently to deliver 50 million doses by January. They are working on this.
By January?
Yeah.
Yeah.
Well, they've already started the manufacturing product, which they normally would not do. You would wait to have an approved product to start manufacture, but because of COVID, a lot of these companies have already started to manufacture. That's why.
Yeah, I mean, they took a gamble, and in this case, for Pfizer, that gamble may indeed pay off. One thing that we don't know is how serious the infections were in the trial, whether the vaccine prevented really serious infections or just the usual one that 80% of people get over anyway. So that, and also it isn't clear exactly what the population was made of, whether or not there were enough seniors in this 94 group to make any kind of interpretation of that. So there certainly are questions to ask, and there also are issues with production of this vaccine, because I'm sure, as everyone has heard, it has to be transported at a very low temperature, which is -70 degrees Celsius. And the reason for that is because of the particular way that the antigen, the active ingredient in this vaccine is delivered, which is in these tiny little nanoparticles, they're called. the virus, or at least the messenger RNA is encapsulated in these little nanoparticles, and those are the ones that don't stand up to temperature. So it all has to be transported at -70 and kept at -70 until it is thawed out, and then it's good for 5 days. So it is possible, that it can all be organized so that clinics and doctors' offices will have this delivered, and for 5 days, it will be good. But it's going to take quite an effort to do this. But another important thing to understand here is that this is a proof of principle that messenger RNA type of vaccines can work. We didn't know that before, so that's a very important.
Are there any, there's no other vaccine?
Yes, Moderna. Moderna is in the same category. It is very similar. It's a messenger RNA vaccine, and they're also in phase 3 trials. And I'm sure they will try to push out their results very soon now, because.
But there's no other. Yeah, I'm sure they will. But there's no other vaccine that we use routinely that is a mRNA vaccine.
The most recent Ebola vaccine, Joe, that was approved last summer. Is it an RNA vaccine? Is it a DNA vaccine?
I don't think it's an RNA vaccine. I don't think so. We have to check that. But as far as I know, there are no mRNA vaccines that are in production.
So all our normal vaccines that we just say vaccines, on a scientific point, they're all DNA vaccines?
No. So they're usually, either the protein, a specific protein from the virus. Sometimes it's the entire virus that is sort of inactivated, that is attenuated. But for the first time, we are using the blueprint that will make part of the spike protein of the virus, because it's a lot faster to produce than to make a protein-based vaccine. And these types of RNA vaccines have been in the works since the 1990s. So it's not a new technology per se. For decades, scientists have tried to make it work, but for a variety of reasons, it hasn't really panned out. But now we're spending so much money on this, and then the delivery mechanism of the RNA, as Joe was saying, the nanoparticles, all that kind of stuff is relatively new. And so now we seem to be on the cusp of potentially a sort of a revolution in quickly making vaccines that are efficient and that are easier to produce. But again, so you get this ultra cold chain that you need to have in order to keep them stable.
It's also the question of who's going to get this first, how that is going to be.
All the countries are starting to sign deals, and a lot of politics going on now in each country trying to procure the virus.
But I think the consensus is that it's healthcare workers who are going to get it first. So you may be the lucky one in this group.
Healthcare workers in rich countries. I was reading that Oxfam was saying that something like 2/3 of countries will probably not have access to a vaccine until 2022. Because so many rich countries have made deals with these big pharmaceutical companies saying, I'm going to buy all these vaccines that you're going to make. And so the poorer countries are like, well, there are no doses left. We're going to have to wait. So that's another issue.
Of course, and we're talking about Pfizer producing 50 million doses by January, which sounds impressive. But the fact is that when you're talking about having to vaccinate billions of people, that's what we're talking about, in order to try to achieve herd immunity. 50 million doesn't go such a long way.
And many of these vaccines require 2 doses. So now you have to double everything up. If you want to immunize, one person, you have to have 2 doses.
Yeah.
So we haven't even discussed the whole who will accept the virus, who will accept the vaccine, the vaccine movement. And that's a whole other kettle of fish. And, when it comes to COVID, it's even has more political issues, and
those numbers are scary. Because they're the numbers that I'm seeing now, like 35% of people are saying
because people it's because like we said previously on the webcast, because for a COVID vaccine fit into that vaccine hesitant. I don't want to say that, but fit into this particular vaccine hesitant scale, because when we were talking about Trump making it and having it in time for the election, obviously I was going to be vaccine hesitant, even though I'm pro-vaccine. But this one coming out, if the phase 3 trial looks good, and the Fauci's and Paul Offits are on board.
Of course, everyone wants to wait for the evidence, right? No one wants to be a guinea pig.
No, but maybe the numbers of then vaccine hesitant people will go down, and it'll just be on par with like the normal vaccine.
Interestingly enough, there are a lot of people who are quite willing to be guinea pigs. The 44,000 people that we're talking about here in this study. Also, Celia, you were saying that there might be some selection bias here too. In
Absolutely. I mean, the people who sign up to, in general, to people volunteer to be taking this vaccination certainly, might not come from the sort of bell curve of the population. There's certainly a certain type of person who may act differently. These people might be more cautious, or certainly when they're out, it just, so the number of cases you were saying was a relatively low number of cases in the 44,000 people, and that might just come from the fact they might behave differently than a bell curve in the population.
And they we're also more comorbidities.
Yeah, and
right?
we're also going to see a selection bias with the human challenge trial that's been greenlit for Great Britain, because that's a lot of young people who feel a little invincible, and they're like, well, I'm not going to get too severely sick, so I want to get an experimental vaccine. I want to be given the virus to see if the vaccine works. But again, those people may not be representative of the population at large.
And I also think about maybe even the other way. There are a lot of people who say, well, I'm young and healthy, and I'm not really nervous about COVID. It's, COVID is, if COVID acted like Ebola, then, there'd be much less vaccine hesitancy than COVID acting like it does, where, we sort of, some people get really, really sick, and some people in the same age group can be totally asymptomatic. I mean, we just don't know.
Are you hearing the same kind of vaccine hesitancy there as we hear here?
Absolutely. I am hearing it. And definitely, yeah. And it's interesting, because you have, again, like I was saying, you have people who are totally asymptomatic, and then you have people like, today I did a shift this morning, and I had, I think, 3 patients that I saw this morning coming in with sort of post-COVID syndrome that's only starting now to, sort of understand it a bit better. But people coming in with so the people who have recovered from COVID, even if they had a relatively mild case, we're seeing things like people coming in with 3-4 months after, chest pain, shortness of breath, weakness, fatigue. We had a patient last week who came. The taste and smell can also last long. These are people who are coming in really. They said, I walk up a flight of stairs and I'm having chest pain, I'm having shortness of breath, and this is going on for quite some time. I saw a patient who had 4 months. 4 months of daily chest pain after COVID. I mean, we did a workup, everything was negative, but having a sort of post-COVID syndrome. And we've also had patients, we had a patient last week who had a post-COVID cardiomyopathy, which that's like an inflammation of the actual heart muscle itself. So we're seeing all these, sort of post-COVID syndromes that we're just starting, the whole world's just starting to learn about that. So that'll also—
And that's only the physical. Waiting until the mental.
Absolutely. Yeah, for sure. No, yeah, for sure.
Yeah.
We've talked before about testing, and of course there are many different kind of tests out there, but basically they fall into 2 categories. The tests that will tell you if you have active disease, and these are the so-called PCR tests, where tests for the genetics of the virus. And there are those tests that will tell you whether or not you've been previously exposed, which are the antibody tests, which are not that reliable. But now there's this new test that they're talking about, which is the T4 cell test. And the T4 is a type of white blood cell. The T stands for thymus, because these are produced in the thymus gland. And when you have had an infection, the T4 cells also increase. It's not only antibodies that increase, that these cells increase, and they also can attack the virus. So it seems that the test that they're developing now for the T4 will give a better picture of who's been infected than the antibody test. The only thing that I see from just having a quick look at these new tests is that they're not speedy. It's quite an effort to test for the T4 cells, but one thing certainly that this situation has done is triggered a lot of innovation. I mean, the work that is going on to try to find all the new tests and vaccines, it's very, very impressive. So in Israel now, what tests are you using mostly?
We're still using the PCR, which sort of otherwise known as a swab. The swabs, that's the main test. And for people who require the antibody test, we're doing the regular antibody test. At one point, I had the antibody test. In the beginning of COVID here in Israel, we had the COVID hotels. We still do, but they were very busy.
I was going to ask, how they're doing.
So we still have the hotels. There's much fewer patients in the hotels these days, but at one point in the country, there was many hotels all over the country. And part of the work we did in TEREM, which is what I'm the medical director of, is that we would go, we were asked by the Ministry of Health to treat all the patients in these hotels at one point who had other issues. Or someone could have had an abscess and needed drainage, or twisted their ankle, or any other thing that people living in hotels sometimes for a month or two, and they'd have other medical conditions. And so we would go, and I would go once a week myself and drive up to the north of the country, around the Sea of Galilee, and go visit these hotels. And you'd literally, sure, I'd be wearing the full, hazmat, what we call it, the full gear, but I'd walk into 4 or 5 hotels, often treating hundreds of patients, or not treating hundreds of patients, but being around hundreds of patients all over the place with COVID positive. These are all COVID positive patients. And when I finished those, did that for about 10 weeks. And when I finished that, so the government decided to test the doctors who were doing this kind of work. And I mean, I thought, I thought for sure I'd be at least have the antibodies, because you have to really take off the very carefully. And anyone knows me, I'm like a little bit ADD. I might not do things like exactly like there's a reason I didn't go to surgery. And even after all that, I was still negative for everything. So,
do you still like employ the same caution, like you said, or you saw 3 patients yesterday or this morning that were COVID positive 4 months ago? I know they're not COVID positive, but do you still get because here I think we do, the family doctors would be like, oh, they had COVID a while ago, and you're still nervous, but
no, I mean, I think, yeah, after doing those hotels, I kind of lost my nervousness. I mean, I'm still, at one point in the beginning when we didn't really know about how it was transmitted, and we were talking, is it by, people were washing their fruits and vegetables, and enough people are still doing that. But so I would come home and sort of take all the clothes off outside and go through 3 levels of sanitation. So now I'm a bit more reasonable, I'll take a shower, of course, right after a shift. But I'm not going through the 3-level sanitation outside and whatever.
No, but that's interesting, because I know Debbie was also doing the same process. She took off her stuff, put it in a plastic bag, let it sit there, and you said something similar. But you're still employing caution, but not as washing fruits and vegetable on that end.
Which I never did, but yeah.
But also you also don't want to be COVID fatigued. You can't afford to be, right?
No, you still have to you have to employ some caution, but certainly now that we know better, little bit better about the transmission, and that have to be too worried about it,
Right.
So you're no longer burning your clothes after each shift,
I'm not
which
burning
is very expensive, I'm told.
It is, yeah. Especially with the number of shifts.
You keep wearing scrubs just over and over.
There's constant talk here, of course, about PPEs and efficacy of masks. And just this past week, there was a story that 3-layer masks are superior, and bandanas are no good. I mean, some of this we've heard before, but the question is, what does that mean, 3-layer masks? And the mask that we normally use, which, normally, I mean, a lot of people use, is this one here, which is the so-called surgical mask. Although there are several different types, but these are 3 layers. Mm-hmm. Which I know because I did an autopsy on one.
I saw the autopsy.
So you can see the three layers. They're made of polypropylene, and anyone who objects to the use of plastics in our life, think about that. These are made of polypropylene, but some of the other masks, the fabric masks, some of them are just one thin layer of cotton. Some of them actually have 2 layers. Some have a little pocket. They tell you to put a piece of paper towel in there and all of this. I don't think it makes a whole lot of difference. What makes a difference is to wear a mask.
I agree. I agree with that. In Israel, there is a law to wear a mask everywhere, inside and outside. It's actually a law. You'll get a ticket, quite a big ticket if you're caught outside not wearing a mask. You're allowed to run. You're allowed to exercise not wearing a mask. So you don't have to have a mask if you're running. So you say running is a state of mind, or exercise is a state of mind. But still, I mean, you have to wear a mask everywhere. I mean, and indoors, obviously, for sure. I think masks are much more important when you're indoors. Being outside with a mask, you can debate the efficacy of, if you're, I guess if you're in a big group or a mass of people, or, then certainly
like if
especially
you're in a
standing.
protest.
If you're in a protest, everyone likes to give that example. Or if you're even picking up your kid and people are speaking and all around, I understand that for sure. Even if it's outside, that's a good. I always wear a mask outside for that reason. But if you're going for a walk with your family down the street, or if someone's then the chat, and you're not stopping to talk to anybody face to face, then I wonder about that. But it is the law here. So,
well, here that's not the law for outside. It's just a law for indoors, which people are abiding by. I mean, you go into any kind of store or shopping center, and everyone's wearing a mask.
Although we see a lot of this.
A lot of that.
Yeah, a lot of that. Yeah.
Yeah.
I need my nose to breathe.
The chins. Yeah.
And I tried, and I said this to Debbie also. I was curious. I mean, CDU too, although it sounds like it's a little bit more harsh there with the ticketing. But the best way to say something, like, have you ever been in an instance, and Joe, you too, where you've noticed someone's not wearing a mask inside properly with you, and you want to say something to them, but it's sensitive, and how do you say it? I mean, some people don't care. Just like that. Exactly, Jonathan. Right. So the other day I saw someone, and I didn't say anything. Like, I just didn't know what to say or how to do it. And I was like getting out of there anyway, but I was so annoyed.
It's a touchy business.
Very touchy.
I think more so in the US than here, but they
might have a gun.
Exactly. Exactly. They're I mean, we've seen fistfights in donut shops over this kind of stuff. So yeah, I don't know if I would want to approach someone. Depends what they look like.
My rational thought is that at least they're covering their mouth when they're doing this. So yeah, okay. So the nose is not covered. At least the mouth is covered. So it's better than not having a mask. I mean, it also kind of riles me up, but at least it's a half protection is better than no protection, I suppose.
In Israel, there's a much less personal privacy or space in the Middle East, so people have no issue. I'm on a bus a few times a week, and if someone's like mask goes under their nose, the bus driver sometimes will look up and yell right at them, or people sitting next to them and go, "On your nose!" Oh, sorry. So, they'll wave their hand back and forth, but they'll do it. So there's a lot of that. No fist fights that I've encountered yet, but
yeah. Well, I think. Here people are not quite as willing to accept it. But we'll see. I mean, we may eventually have a regulation here too, where you have to wear the mask everywhere.
Outside.
Because, I mean, let's face it, right now, with the way things are going, with people wearing masks indoors, the numbers are still rising.
So what would you recommend? Sorry,
go ahead, Emily.
I was just going to say, what would you recommend, like Joe and Jonathan and Stevie, if you were to talk with Legault, like here in Quebec?
Well, the question is, where are these, especially these super spreader events, coming from, right? And I don't have access to that kind of granular data. I have read in the mass media that a lot of this are like parties and gatherings that are not home gatherings that are not allowable. So if that's the issue, mandating masks when I'm going out for a walk outside, it's not going to solve the issue, and it's going to create a lot of tensions. So I think we have to figure out where the main problem is and act there.
It's a good point. Once you have a super spreader patient or event, then even masks aren't 100% effective. I know of cases like, for example, on Yom Kippur, the high holiday here, they had a temporary allowance to go back into synagogue with a certain number of people and that kind of thing. And there was one of the synagogues here they were all wearing masks, but there must have been a super spreader because the entire synagogue, they only allowed 20 people in there at the time. They stopped that. It was only for a one-day thing for for Yom Kippur here. They made a special exception, but that one synagogue happened to have a super spreader.
Even with the masks?
Even with the masks, because again, masks are great when you're talking to someone, you're passing by them, you're spending a few minutes with them, but you're on a Yom Kippur prayer service,
right?
Which everyone knows might be 4 or 5 hours,
longer than 15 minutes.
Longer than 15-20 minute conversation. Then certainly the masks are effective, but only to a certain point. And if you're a super spreader, they're certainly not 100% effective.
Because a regular medical mask is not a respirator. I mean, it's open at the sides, and so you can imagine all these particles that are in the air for hours and hours. At some point, they're going to come in through the sides, and you're going to breathe them in.
Exactly. So sorry, I think that kind of gathering, or those kind of being in a house or in a closed space with a lot of people for a long time, even with masks, that should be really monitored more closely.
I have to say it, I think my friends will kill me, but like, I think schools should be closed for a bit. I mean, just to even see if we closed them for a month or 6 weeks, how the numbers would fare. Only because I think that some of those household gatherings can also then translate to schools, right? So if it happens in the household with the 10 people, then the kids go to school. And I'm not even talking about 4-year-olds, but let's say 14-year-olds, then at that point they're spreading it.
So I think that was the idea here, in the sense that, there's a lot of literature and studies that show that, not being in school, can cause a lot of psychological issues and for kids. So it's a very, have to weigh that very carefully. And the interesting part of what I was reading about that was that the younger the children are, the worse it affects them. So that's why here they put their little kids back in school slowly. They started off just with the kindergarten kids, and after
you mean psychologically, not the infection itself?
I mean psychologically. Sorry, yeah. I mean, yes, long-term psychological effects and that kind of issues. Yeah, not the actual virus itself. So that was the idea here, was to get the younger kids back, in school, social. That's how they develop, right? Being within social situations, and they did it first kindergartens. Now they did up to grade 4 after 2-3 weeks, very, very slowly. But all the rest, from grade 5 up to the end of high school and college, university, no one's back in school. Because again, although it's important, it affects them psychologically long-term less than younger children who need to be. So that really has to be weighed. There was interesting literature after the Spanish influenza that kids who, especially younger kids who were out of school at that point, I think they were out of school for like 2 years or something, ended up doing much worse in life later on, lower socioeconomic status, lower education levels compared to other populations in different years. So it has to be weighed carefully. Not an easy decision. Not an easy decision.
Obviously, the economic impact and the store closures and restaurant closures are going to have an effect on people's mental state. I mean, people can't pay their rent, and
absolutely,
it has consequences all over the place. Okay, let's just before we finish off here, let's just review what we know now that we didn't know at the beginning. When, let's say, the beginning March is when we started to get tuned into this. So what do we know now that we really didn't know then?
Well, transmission is a big one, right? I mean, we were, kind of a little bit paranoid about surfaces, about these so-called fomites, and now we're much less so. I mean, it's not that they don't play a role, but we don't think that it's a primary mode of transmission. The whole debate over is it airborne or not? We have a better idea that, in some situations, especially when you're indoors with a lot of people over a long period of time, airborne transmission is quite possible. So I think that's one of the big things that we've learned, is how is this virus transmitted?
Sidi, what about treatments?
Oh boy, you mentioned some of the drugs that are out there, new, especially and more importantly, the non-ventilating people. That was a huge thing that happened in the beginning, where they were putting people on ventilators and talking about mass production of ventilators. And now we know that ventilators are not the best idea, and try to limit that as much as possible. It's actually interesting. I almost look at it differently. How much we don't know still. We don't know how long this will affect people. We don't know this post-COVID syndrome and how long these symptoms will last. And we're still hearing stories of people who are getting it twice. I don't know if that's talked about at all in Canada, but how long does the immunity last? We don't know that either. After you've had it, and if it lasts forever or not, and is the second time you get it worse or better? You expect often, like when a kid gets a chickenpox vaccine, they can still get the chickenpox, but it's usually milder. And here we've had stories in the country of people getting COVID for the second time and getting it much worse. So there's so much out there we don't know.
Right. There's no rhyme or reason. It has no. It's just whatever. It's like whatever it wants any day, any person.
Once you take out the age, if you have there's certainly the age and medical risk factors, but in the same age group, why would one person get sick who has none of those risk factors, one person not?
And another big discovery is also the confirmation of asymptomatic carriers. The fact that so many people show no symptoms but can also transmit the virus.
Actually, it's interesting you bring that up, because someone asked me today by email, is how do we actually know that? What is
how do we know what?
The evidence for asymptomatic carriers?
Testing asymptomatic people?
We all know, right? We all know that these exist, but how do we know?
Well, yeah, because when you do test these people, you will find the virus there, and you expect that the test is accurate, this particular test result, but the person has shown no symptoms. So it's this association between the test result and the lack of symptoms.
Right, but how do we know that they actually can transmit the virus?
Well,
right. I mean, all we know is that. I mean, I think we kind of assume from seeing the whole spread, and that that you have all these situations where nobody seems to be symptomatic, and yet eventually it turns out that many of them have come down with it.
But one thing also that's still a big question mark, and maybe we could just talk about that before we leave, is that CD was telling me before we went live that recent in the last hour, Israel just announced a change to their quarantine policy, which I'm interested in because I really want that to change in Canada if and when it's appropriate.
So do I. I usually come back 10 days every 2 months. I haven't been back since January. So Israel had a quarantine policy. It was already a bit less than Canada in the sense that if you were landing in Israel from a green country or a country that had low rates of infection, you didn't have to go to quarantine. But everywhere else you have to go into 14-day quarantine. Canada has the 14-day quarantine, and Israel just announced actually today, within the hour, that they were decreasing that to 12 days instead of 14 days, but requiring 2 tests. So you'd have to have a test as soon as possible from when you have to go into quarantine for whichever reason you have to go into quarantine, either landing from a different country or you've been exposed to a positive patient, and then you'd have to have a negative test on day 10. And if you have negative tests on day 0, let's call it, for example, day 1 and day 10, then you can come out of quarantine day 12, which is a change. 2 days, okay. I guess we know from the literature that it's although they say a 14-day incubation period, it's much less likely after 10 to 12 days of being asymptomatic to still have it. And that's for the general population. Actually, for the medical personnel, they changed that a few months ago. So you have to have also 2 negative tests, and you can come out day 10 already. So medical personnel, because of the need for them, obviously an essential worker. So medical people, if they had 2 negative tests on I believe day 5 and day 9, they can come out on day 10.
What's the reasoning for a non-healthcare worker to get a negative test on day 10, but still have to wait an extra 2 days before coming out of quarantine?
Oh, I think it was I think the test on day 10, and they expect the test to come back within 24 days.
Oh, I see. Okay.
Right. Yeah. So I guess if you went for a rapid test, you could do it on day 11, but it was like the 12-day total.
Right. Okay.
Just one last thing: the flu vaccine, which of course everyone is saying we should get, and of course we should. But now I'm beginning to see some published literature, interestingly enough, which shows that the flu vaccine doesn't only protect you against the flu, it may actually have a positive impact on protecting you against other coronaviruses as well. Have you seen anything about that?
I haven't seen anything about that yet. No, That's interesting. I just got the flu shot.
I saw a couple of papers about that basically just revving up the immune system in any way, which is what vaccines do, can benefit for all antigens.
So it's not just drinking like green tea and boosting your immunity that way.
No, I don't think that kind of boosting immunity with eating things or drinking things. No. Although there's nothing wrong with drinking green tea. There's a lot of very interesting.
But it won't do what a vaccine does.
Yeah.
But
what a vaccine.
I would also expect this year. I mean, people are saying that. I've read about that. You expect the flu to maybe not be as prevalent this year because people are being so much careful with the hygiene and social distancing and all those things.
For sure.
So you'd expect sort of a lower number of influenza cases, but that's yet to be proven. But that's sort of the theory.
Lower number of common colds as well.
For sure.
Because it's.
And then until people start feeling an itchy throat or something like that, and then I have some friends who's a doctor, and she does like the Allegra test. Like if you feel that, but then you take an allergy medication and it's gone in 24 hours, like you don't need to worry anymore. People still do get sick with things, and then you start getting nervous that it's
absolutely that's going to be the hardest thing this winter is when people coming in with flu. Is it flu? Is it COVID? There's certainly so much overlap there that certainly there are little nuances of difference, but we all know nothing's textbook, so it's going to be very difficult to know.
Yeah.
Okay, Emily, 2 weeks from now.
Yes, 2 weeks from now, our last one in November, crazy. We will be speaking with Professor Jonathan Kimmelman, who was supposed to be on a few weeks ago, but there was a schedule conflict. So he's coming on in 2 weeks. And again, it'll be interesting because he talks about, vaccine development and the ethics around vaccine production. And Jonathan, you've spoken with him before about a few things.
I know him. Yeah. He's a very wise thinker, and he's written a lot of very interesting pieces about scientific research. The gap between animal studies and human studies and issues with that. So it should be a very interesting conversation.
Right. So right here, 12 p.m. on the 26th, and look for it on social media.
And all our previous sessions can be seen, right?
Yes. Also on our YouTube channel, there's a COVID and More playlist. So if you didn't catch anyone and are just interested in checking it out, go for it.
And of course, if you want to subscribe to our weekly newsletter, which is free, just go to our webpage, which is mcgill.ca/OSS, and you can sign up, and it will appear at exactly 6 a.m. Eastern time every Saturday morning.
Or via carrier pigeon. There's another option. There's a box you have to tick.
Right. Yeah.
Okay. Thanks to everyone. CD, all the best there. Good luck with bringing down the numbers.
Yeah.
And we'll see.
And we'll have CD on again. We thought in maybe the new year, or even in December if we want, talking about some other interesting things that you do as well that aren't only COVID specific.
So true.
We'll
Absolutely.
Yeah.
I'm looking forward.
Okay.
Thank you.
All right. Thanks everyone, and see you in 2 weeks.
Bye.
Bye.